at UCLA. She'll be speaking on cardiovascular magnetic resonance in women and renally impaired patients.
Thank you so much, Dr. Prosper. Good afternoon, and thank you for coming back to our session despite the beautiful weather outside. These are my disclosures. In this presentation, I will describe the need for tailored MRI in women and in patients with renal impairment. I will focus on ischemic vascular disease, including peripheral arterial disease, and will highlight new MRI methods that are being developed for evaluation of ischemic vascular disease in women and in patients with renal impairment. So why tailor MRI for women? From numbers alone, women make up 50.5% of the US population. And if we look at the figure on the left, right about 60 is when the number of women outweigh the number of men. And so what we're looking at and what we do know is most cardiovascular disease processes and many other age-related diseases tend to coalesce around midlife. And so as we get older, the customers that we'll be serving are typically older women. Aside from the numbers alone, there are differences between men and women, and they have different needs. That comes down to anatomy, physiology, and blood volume. So if we tailor our imaging protocols and techniques, we may be able to improve specificity for diagnosis and monitoring and prognostication of highly prevalent diseases for both men and women. For women alone, there are two major life events that happen in us. For those of us who do get pregnant, there are changes in our blood volume that completely change our physiology. We have to think about safety in the setting of imaging because there's another life involved. And then towards the end of our lives, we think about menopause, which is at the time where women lose their estrogenic protective effects. And that's when cardiovascular processes begin to set in. What about patients with renal impairment? What does that imaging outlook look like? It's actually fairly common. And in 2017, there were 844 million people who have chronic kidney disease. That's approximately 1 in 10. So if you look around the room, that's pretty common. And then chronic kidney disease is also more prevalent in women, the elderly, patients who have diabetes, hypertension, as well as racial minorities. And actually, as a cause of death, it's estimated to become the 5th cause of death by 2040. So CKD represents a large burden of disease in low and middle income countries. It is among the top 10 causes of death in Singapore, Greece, and Israel. So it then makes sense for us as people who develop imaging methods, MR specifically, that we think about non-contrast methods for these populations, as well as potentially explore kidney-friendly contrast agents. There are macrocyclic agents, and then there are also iron-based agents, which we've been exploring a lot of. So this map shows the global burden of cardiovascular deaths in CKD. The colors encode age-standardized deaths per 100,000. And in 2013 alone, cardiovascular deaths due to reduced eGFR outnumbered the number of deaths in patients who have end-stage renal disease throughout the world. And that basically means roughly about 21 deaths per 100,000. So these numbers are not inconsequential when we think about the population and people who will be using our technology or are in need of our technology. At the core of ischemic vascular disease is a problem of tissue perfusion. However, if we image the vessel walls, the plaques, and flow attributes, these types of information provides insights into the mechanisms of ischemic vascular disease. When we think about perfusion, we often equate that with flow, but actually blood supply is a function of flow and volume. Whereas when we think about perfusion, again, we think about flow, but perfusion is a function of flow, volume, and oxygenation. If we take a look at the heart as a sample solid organ, it's a muscle. It has a macro circulation system consisting of the aorta and the epicardial coronaries, but also a microcirculatory system consisting of the smaller vessels. And the differences in the characteristics of the vessels allow them to function in a different way, in the sense that larger vessels have different layers, the endothelium, the intima, the media, the adventitia, that allow them to contract and vasodilate. Whereas for capillaries, they can't do that. They're either on or off, but they serve as a reservoir for blood volume reserve in the setting when we need that additional blood supply. In most vascular beds, there are autoregulatory mechanisms that allow us to maintain perfusion, and that happens by increasing flow. But beyond the autoregulatory zone, there has to be another mechanism to bring additional flow so that there's more blood supply. Dr. Janet Wei did a beautiful presentation on ischemic heart disease, so I will incorporate some of aspects of peripheral arterial disease that Dr. Peter Lawrence, who could not be with us today, into my talk as well. So peripheral arterial disease is actually very common, and it becomes even more common as we age. And as an ischemic vascular process, it affects 8.5 million adults in the US, and more than 200 million worldwide have PAD. The prevalence of PAD continues to rise and has grown by 29% in low to middle income countries and by 13% in high income countries. The PAD prevalence and incidence are both sharply age-related, if you recall my initial slide, rising to more than 10% among patients in their 60s and 70s. Although men are traditionally viewed at higher risk of PAD than women, the true prevalence and incidence are inconsistent among available reports because many of the earlier studies don't necessarily separate out sex. What we do know is that the prevalence of PAD is higher in men than in women, and you can see that in this figure. However, when we look at the actual burden of PAD, more women actually have PAD than men, and that may relate to the fact that there are more older women than there are men. But there may be other causes, but we'll take it for what it's worth. Screening for PAD is done using an ankle brachial index, the ABI. This was developed in the 1970s. 70 years later, we're still using this to diagnose peripheral arterial disease. It's very simple. It is the ratio of the systolic blood pressure in the ankle relative to that of the brachial artery. And an ABI less than 0.9 gives you the diagnosis of PAD. However, it's not very specific. It is sensitive in the sense that in some cases where the ABI is 0.9, patients do not have symptoms of claudication. In other cases where the ABI is greater than 0.9, but patients do have claudication. And so it can be a bit challenging, and surveys have been used and developed to be used in conjunction with the ABI to diagnose peripheral arterial disease, but it's not perfect. Other methods include duplex ultrasound. Digital subtraction angiography is an invasive test, and it's only reserved for discrepancy between non-invasive methods. And then we have CTA and MRA, but those are only used or are considered advanced techniques by which they're used as vascular roadmaps for planning procedures or following up to see how well the procedures perform after the stenting or the vascular surgery. Women actually have additional risk factors for PAD. They have traditional risk factors, including diabetes, hyperlipidemia, hypertension, smoking, but then there are also non-traditional risk factors. For them specifically, women who are pregnant, if they develop preeclampsia, and then during menopause, when they lose the estrogenic effect, these factors increase their risk, and because of that, the burden of the disease in older women is actually higher than that of older men of the same age. And if we look at this figure, which separates out the prevalence of PAD in women stratified by ethnic background, we notice that patients who are of African American origin or are American Indians are at highest risk in terms of prevalence relative to other groups. In the same manner, having CKD may represent an independent risk factor for PAD, and it's actually underdiagnosed in patients with CKD, and you'll find out reasons why. PAD is more prevalent, and that range is anywhere between 12 to 38%. The risk for severe PAD, including amputation, is markedly increased even at CKD stage 2 and 3. Those with CKD are offered fewer revascularization procedures than those without CKD who have comparable PAD severity. And this may be related to higher risk of complications in CKD, poor functional and nutritional status, advanced wounds that are deemed unsalvageable, or simply the concern for contrast-induced nephropathy. And so this population has unique needs in the sense that the ABI is not accurate because the incompressibility of the vessels leads to falsely normal ABI values when they do have claudication, or they may not have claudication but have PAD. And so typically the toe brachial index is actually used, but it's a little bit challenging. And in those receiving dialysis, vascular access is always an issue. And so in this particular population who are on dialysis, needle-free, non-contrast types of methods may be ideal for them. If we are able to get access for contrast agents, and obviously ferriheme, ferrimoxidil, other variations of iron-based agents may be ideal, partly because we don't need to worry about the creatinine issue or the kidney issue, and they need it anyway. So what type of information do we wish to gain from MRA? We had a big discussion about this yesterday, and obviously we want to see large vessels, small vessels, arteries, and veins. And so with whole body MRA, non-contrast, you can see multi-bed vascular disease from head to toe. This is actually quite significant in patients who have CKD, and there's actually a trend or growing interest, I should say, to learn more about multi-bed vascular disease, partly because they increase the risk and mortality in our patients. And so the ability to actually image the entire vasculature and figure out the global burden of atherosclerotic disease actually is quite important. Other information such as vessel wall depiction. There was a discussion about this yesterday, just being able to see different aspects of the vascular wall and how they contribute to the overall function is important. And then plaque composition. These images show carotid plaques as well as coronary plaques, and probably the next person who will be the next Bill Gates or Elon Musk will probably, whoever comes up with figuring out which plaque is actually the vulnerable plaque or the plaque that will rupture. And then this morning, you've heard a lot about 4D flow MRI, and that continues to be an area of great interest. And then indirect measures of both macro and microvascular health, either gadolinium first pass, which is now considered standard reference. It is a concern for patients who have kidney failure, however. There are bowl techniques, ASL, fractional blood volume, and then CEST and PAD, which I'll discuss in a little bit. And so for both women and patients with CKD, there are safety considerations if we plan to use contrast agents. Currently, there are gadolinium agents. Most are extracellular and can be classified as macrocyclic or linear agents. There is a safety warning associated with gadolinium, and that's NSF in patients with dialysis or severe kidney disease, and soft tissue deposition regardless of renal function. And more recently, there are new guidelines from ACR that do not recommend routine checking of the creatinine in patients without risks for renal dysfunction. We'll have to see in the next few years what will become of those recommendations. And then alternatively, one can have off-label use of USPIOs in this particular population because both women and in patients with CKD both are anemic iron deficient. So Ferriheme is one agent that we've discussed. It's commercially available, has high intravascular fidelity. It is not metabolized by the kidneys. However, it carries a 1.8% risk of mild and a 2.2% risk of moderate adverse events. It also carries an FDA black box warning label for therapeutic use. As of July 2021, generic Ferrimoxyl became available, and another alternative agent that's ripe for clinical development is a compound known as multi-ion. There are several oral presentations and power pitches throughout the scientific sessions on the off-label use of ferrimoxetol and multi-ion that I encourage you to attend. And so in the next few slides, I'd like to show you some methods can be adapted for women and patients with chronic kidney disease. This figure came from our paper in radiology from a couple of years ago, where we demonstrated that ferrimoxyl enhanced MRA can be used along with non-contrast enhanced CT to assist with vascular access mapping, and the yellow and the vascular calcification that's shown here represents vascular calcium. Over the last year or so, we've using Siemens whole heart whip, we've incorporated this into our Ferriheme fractional myocardial blood volume framework, and that has helped us with our ability to detect both macrovascular and microvascular disease. Another approach is through image fusion, and this is work done by Take Yoshida, and you may have heard his work yesterday afternoon. This image is from one of his papers in the Journal of Vascular Surgery 2 years ago, and you can see his beautiful rendition. A shows the ferrimoxyl enhanced MRA image. B shows the non-contrast CT with the vascular calcium. He puts it nicely together, and you have this very beautiful 3D volume rendered image on the right. And this is a movie of another patient, a 3D model that Take has created. And notably, this patient has a pacemaker. It's also a 78-year-old female who had moderate renal impairment. And typically for us, when we do structural cardiovascular procedures, kidney impairment can be associated by worse outcomes. And so if we cut down on the use of contrast agents during the perioperative planning process, then overall that reduces the total contrast load intraprocedurally. This work is actually from Dr. Saloner's group up at UCSF. These are images of an arteriovenous fistula, and this brachiocephalic fistula is failing, and it's about more than a year after the surgery. So the image on the left is a time of flight acquisition. The middle is with ferrimoxetol, and the right is digital subtraction angiography. And you can clearly see that there are two areas of stenosis pointed out on the ferrimoxetol image, whereas with the time of flight, it's difficult to see the other stenosis. This is work from Dr. Rodidi's group at University of Glasgow, where they use ferrimoxyl enhanced MRA in patients who are undergoing renal transplant evaluations to evaluate different aspects of the renal vasculature. And I'm going to move forward because I only have 6 minutes left. So more recently, our group has been working with multi-ion to help with our cardiovascular images. And this is manufactured by BioPal. It has been used for cell labeling and preclinical imaging. And according to the manufacturer, multi-ion was designed to have attributes very similar to that of Ferriheme in terms of its R1 and R2 relaxivity, the biological half-life, as well as the safety profile. So the images on the right that you've seen has been acquired with our multi-phase MRA pulse sequence with contrast enhancement. And if you're wondering which contrast agent was used in this image, in acquiring these images, please come to Zhang Yang's power pitch tomorrow afternoon. And then, okay, I have 5 minutes left. Other methods that we can use for perfusion and energetics might include fractional blood volume mapping, bold imaging, or chemical exchange saturation transfer for energetics. So this is Caroline Colbert's work, where she has taken feramoxetol along with a Molly sequence to look at T1 reactivity. And T1 reactivity is the percent difference between the T1 values at rest and at peak stress. And we showed that with feramoxetol, we're able to increase the dynamic range. You can see that with native T1, the dynamic range is much smaller, so therefore it may be challenging in the clinical setting to discriminate between ischemic tissue and remote tissue, whereas with feramoxetol on board, the dynamic range is far wider. Using the same agent, and because of its high intravascular fidelity, she was able to use a 2-compartment model for estimation of fractional myocardial blood volume at rest to depict hyperperfusion. And this is important because we would not have to use stress agents, and it would be applicable for other solid organs for which we're interested in mapping the blood volume. These are images, feramoxetol-derived pixel-wise FMBV maps that are acquired at the basal, mid, and apical slices in a normal swine and an ischemic swine. You can see the white arrows pointing to regions where there is increased fractional myocardial blood volume where we created the LAD stenosis. And since then, Mimi has taken on the challenge and Caroline has passed on the torch. So if you're interested in seeing early clinical data, please come to Mimi's talk tomorrow morning. This is a pulse sequence, a 3D heart rate independent Bolt MRI sequence that can potentially be used for depicting myocardial oxygenation. It was developed in Rohan Dharmakumar's group at Cedars, but now he's moved on to Indiana. So what you see here in part A are T2 maps, both at rest and at peak stress. And the black arrows point to regions where there is a blunted response in the Bolt effect relative to that of remote tissue. And those perfusion defects can be correlated with the PET perfusion images to the right, and white arrows point to those perfusion defects. These are polar maps, B and E, corresponding to the Bolt effect on B and PET MPR on the right. And box whisker plots are shown in C and F, showing correspondence between the Bolt effect in ischemic tissue and normal oxygenation or flow in remote tissues. And lastly, this is an elegant method. SAS for the use of peripheral tissue energetics. Basically, it allows us to indirectly detect molecules that will exchange protons with free water. So, protons in the solute pool will exchange with free water because there's a saturation radio frequency pulse to cause the protons to lose their magnetization. And in that setting, the SAS effect from creatine can be isolated from phosphocreatine, ATP, and ADP based on differences in the amine transfer, proton transfer rate. And this method assumes that creatine from the muscle post-exercise exchanges amine protons with water protons when it is being rephosphorylated by creatine kinase. And the oxidative rephosphorylation removes the hydrogen from the magnetically saturated amine group on the left, improving that SNR. And the advantage to SAS is that we no longer need a P31 coil, and we can just simply use a proton coil. And so this work is actually out of UVA. You see the SAS images on the left with a normal subject and a subject with PAD. On the right are the SAS decay curves, and one can see that the decay is much slower in the subject with PAD relative to that of the normal subject, and the pre-stress images are the first 4. So these are pre-stress, and then these are post-stress images, and this decay corresponds to this signal right here. So in summary, tailoring MR technology for women and patients with CKD merits consideration. Women and patients with CKD make up a robust market share for business. And tailoring MRI for both men and women may improve specificity for diagnosis, monitoring, and prognostication of highly prevalent diseases. MRA technology can provide whole-body vascular roadmaps, vessel wall depiction, characterization of plaque morphology, 4D flow, hemodynamic features, and indirect measures of macro and microvascular health. Beyond non-contrast techniques, macrocyclic gadolinium agents, as well as intravascular iron contrast agents, are available for off-label diagnostic use and may provide initial steps toward tailored MRA and MRI. And I thank all the giants in my life, and I'm grateful to them for their contributions to my growth as a physician